Welcome to Therapy Cafe, the Future of Mental Health, Episode 7, Navigating PMADs, Understanding and Treating Perinatal Mood and Anxiety Disorders, with our guest, Dr. Nicole Pacheco Tchalim. Perinatal mood and anxiety disorders, also known as PMADs, occur in 1 in 5 birthing individuals and include mental health disorders such as postpartum depression, anxiety, obsessive compulsive disorder, and psychosis. PMADs, which often start during pregnancy, can have a significant impact on an individual's mind and body. But there is still a significant knowledge gap among individuals experiencing these symptoms and among practitioners. So unfortunately, we often identify the need for treatment later than we'd like. In today's episode, Dr. Pacheco Challam helps us define PMADs, understand their impact on parents and families, and learn about some of the approaches and challenges treating PMADs. At the end of the podcast, we'll provide information about how you can obtain continuing education for this course. Also, ensure you never miss an episode by hitting the subscribe button. Here's my conversation with Dr. Pacheco Challam. We are so lucky to have Dr. Nicole Pacheco Challam with us. She's a reproductive psychiatrist at Columbia University, where she also serves as the Women's and Reproductive Mental Health WARM Fellowship Program Director. Dr. Challam has a strong background in medication management and psychodynamic therapy. She specializes in providing comprehensive and compassionate care for women and birthing individuals across their lifespans, addressing their mental health challenges and needs related to reproductive and gender-linked transitions. In addition to her clinical and educational roles at Columbia, she is also a psychiatric consultant for Project Teach New York, a free state-funded service that offers guidance and support for New York State medical prescribers who treat maternal mental health difficulties. Through this service, Dr. Challam supports individuals with perinatal and postpartum depression, anxiety, bipolar disorder, and other psychiatric conditions to achieve optimal mental health outcomes during and after pregnancy. Dr. Challam's mission is to improve the mental health and well-being of women, birthing individuals, and their families through evidence-based and collaborative initiatives that reduce stigma and barriers to assessing quality mental health care. Dr. Challam, thank you so much for joining us today. I really, really appreciate it. Can you tell us a little bit about your work? And specifically for our audience, can you help define reproductive psychiatry?
Yeah, so I just want to say, thank you for the invite. I'm really excited to be here. But so kind of what is a reproductive psychiatrist? So, it describes in general prescribers who have particular interests and expertise in providing care to women and birthing individuals. And often some of the primary areas of focus are really during that perinatal period. So kind of pregnancy or really kind of the start of conception up until a year postpartum. And so we're really the people to reach out to if you have questions about mental health treatment, including medication management during pregnancy and the time right afterwards. And then additionally, though, many of us who identify as reproductive psychiatrists also have expertise at all reproductive stages for women, including menses and menopause. And so we do our best to kind of incorporate all of this when we're thinking about our treatment. And we'll often describe that as more kind of like a holistic approach during these periods, right? And, I want to say we recognize the impact that hormones can have on mood anxiety, as well as on medication interactions. And we're really kind of cognizant of some of these other factors that come into play during these times, such as trauma and various other social stressors.
Wow. I never even realized that this was a specialty. So I'm so fascinated to learn more. How did you get into this?
Yeah, so it's a little funny. I always kind of joke and say that I looked at my CV one day and realized I needed to be a reproductive psychiatrist. And so I knew I always wanted to work with women and actually had went to medical school to be an OB-GYN. And I'll say some of my best experiences in medical school was actually on my OB-GYN rotations, which is something very special about being there in the birthing suite with individuals and helping them during that process. I absolutely loved it. And my favorite moment was truly kind of like that time afterwards and being there to support the woman and talking to them about in some of their kind of outpatient settings and seeing how things are going with the new child. And then I also noticed that every kind of paper that I was reading and the projects that I were doing were really from more of like a psychological perspective and from a psychiatric perspective. And so one day I kind of looked at my CV and saw that every single project was in that and realized I was like, oh, I need to go into psychiatry. And then lucky enough, right at that time, someone was like, oh, have you heard about this like new conference that they're having? It's on like reproductive psychiatry. And at the time they were talking about brexanolone, which I won't get into it much, but it's an IV treatment for depression. And it like had not even been like FDA approved yet. It was like very early. And I was just like so enamored and knew that's what I had to go into and started looking into different residency programs where there was like a little bit more of this work being done.
That's amazing. Is it expanding now? I mean, have you seen growth in it from when you got
Oh,
started?
absolutely. So I would say when I first kind of got interested in it, I truly didn't know that it occurred. And when I would ask other psychiatrists, they didn't really know what it was either. I just happened to, I think, kind of meet an OB-GYN who had worked with a reproductive psychiatrist, and she was the one who kind of like helped set me on that path. And then today, I think so many people know about it. I mean, we're constantly having medical students and residents start to reach out. There's also been a huge kind of increase in the amount of reproductive psychiatry fellowships in the last 10 years as compared to before. And then there's also just been more of a push in terms of like general residency programs for there to be more education around this.
It's so exciting for the field too, and for all women really to be able to have these specialties. So
Absolutely.
does it is the acronym go by PMADs or is it just PM? Okay, is it, am I saying that right? PMADs?
Yeah,
Okay.
PMADs.
So tell us about perinatal mood and anxiety disorders, otherwise known as PMADs, and how
Mhm.
common are they?
Yeah, so PMADs encompass both kind of new onset psychiatric illnesses as well as exacerbations during, again, that perinatal period. So from conception all the way until 1 year postpartum. And I really say 1 year postpartum, kind of previously colloquially we would say more kind of like the 3 months. And that's just not true. We really do see that these illnesses can kind of move out towards that last year. And so most reproductive psychiatrists will use that kind of like as the timeline. Okay. And then most traditionally, this includes diagnoses such as like perinatal depression, anxiety, OCD, and postpartum psychosis, which I imagine we'll probably talk a little bit more about today. And they're very common actually during the perinatal period. They're actually one of the most common complications, and they affect about 1 in 5 pregnant and postpartum individuals worldwide.
Oh, wow. So what is the potential impact of it, both on
Yeah.
the individual and their family?
Yeah. So PMADs carry high morbidity. We're thinking about perinatal mental illness. It can have pretty significant negative direct impacts on kind of like emotional, functional, and physical things for the individual experiencing it. And in its extreme, we can actually see maternal death and suicide. I find myself actually thinking about some of the recent data that came out of our state. So the New York State did a maternal mortality review, and they were looking at 2018 data. There's newer data, but they're still kind of looking at it, and they generally found that mental health conditions were the third leading cause of maternal mortality in 2018, right? And so we're
Wow.
really kind of thinking about that severity there, talking about the suicide, and it's not just suicide that you see, but just kind of maternal death linked to that is so high, right?
Wow.
And then I'll mention too, it's not just the mother or the pregnant or postpartum individual that's impacted. We see effects on everyone, right? So that includes kind of the child, other children, and then anyone else in the family, including partners. Okay. And so when we're thinking about kind of like the children who are born to individuals with PMAS, we see that often kind of an impact, particularly on their like social, cognitive, and emotional development. Okay. And then when we're thinking about for partners, we actually do see higher rates of certain psychiatric illnesses. So, for example, there's a few studies out there showing that for male partners, if their wife or their female partner does have a history of postpartum depression during the perinatal period, they're more likely to suffer from depression as well. And so it's really
Wow.
important when you're kind of thinking about treating that, yes, you're treating an individual in front of you, but also kind of everyone else who's part of that family unit as well.
Well, I'm so glad that you all are looking at that when you're doing your research and your interventions, because that does make a lot of sense. We think a lot about screening and diagnostics and
Mhm.
how far behind we can be a lot of times with mental health conditions. How are we doing there? Are there any good screeners or recommendations?
Yeah, absolutely. So, we started this conversation a little bit with the fact that there is more awareness of this going on. And so, I think we see that not only within the psychiatry field, but within the obstetrical field as well. And so, ACOG, actually, which is the American College of Obstetrics and Gynecology in the US, which is the main body for obstetricians, they actually recently released new guidelines around perinatal mental health. And so, they recommend that everyone receiving any 1 woman pregnancy, prenatal, and postpartum care be screened for depression and anxiety using standardized validated instruments. Okay. And then they recommend screening at the initial prenatal visit, later in the pregnancy, and at least once during the postpartum visits. And of course, you'll adjust that based on kind of what's going on with the individual in front of you. Okay. And I can go into a little bit too in terms of like what those screenings are and kind of where to find them. And so for depression, which is going to be really the biggest one they talk about through ACOG, there's really two main validated screening tools that we tend to use. So the first one, I imagine many of the people listening to this have heard of it before, are the PHQ-9. This is commonly used for just depression for anyone, but also it's actually validated in the perinatal period. And it's nice because one, it comes in so many different languages. I think it's been probably like 27 languages at this point, and then it's pretty easily found in things like Epic and other medical database systems, and so it's a little bit easier to plug in. Okay. And then the other one that we see is something called the EDPS, or the Edinburgh Depression Perinatal Screening Tool. This one's a little bit less known, but it was made for the perinatal period, and so it was validated for that period.
Oh, wow.
And what's kind of nice about this one as compared to the PHQ-9 is it actually has less questions about physically how you're feeling, because most women who've been pregnant or postpartum will tell you they don't feel 100% well in terms of their physical
Right.
health. And so having a screening tool that's a little bit more tailored to kind of like the cognitive and emotional piece can be helpful. But either one works really well. They're kind of the way that you screen the numbers are similar. Over 10, you're kind of getting a positive screen, and they both do have screening questions for suicide.
So this ACOG guidelines, are they thinking that is the plan that the OBGYNs are doing the screening during the
Yeah, so it
visits?
really can be anyone. So it can be either the obstetricians who are doing the screening in the actual visits, but I'm sure for again, so many people here who've gone through OB visits, they're quite busy. So it can be difficult for them necessarily to be the primary person doing that. And so sometimes it's going to be done in the waiting room, and maybe it'll be a social worker or administrative staff who's providing that, or maybe it'll even be done at home and they get sent that via kind of Epic if they have like a MyChart or something like that at home, which is basically an online system where they can look at some of their results and do things. And so it really depends on the hospital system, but the goal is everyone should have some type of screening and some way of identifying the positive screens.
So this could be an opportunity for some of our listeners that are therapists, like in private practice, that if they someone's in their office, that they can do these screenings as well, and make
Absolutely.
that a part of that kind of assessment that they would do.
Absolutely. Mm-hmm.
Let's take a deeper dive into PMADs, which I love that I'm just going to come out of this with a brand new terminology plus all this new knowledge. What is postpartum depression?
Yeah. So I'm even going to push back on that name a little bit. We call it postpartum depression, but really we should be thinking about it more as like perinatal depression, and again, that longer period of time. And I say that because the data now is suggesting up to about 40% of what we consider more that classical postpartum depression, so a depressive episode after childbirth or delivery, really actually starts earlier than that. Okay.
Interesting.
And that's really important when we're thinking about kind of like when do you want to initiate treatment and the importance of treating quite early. All right. And then in terms of like really kind of getting to the nitty gritty of the definition, so it's really going to be the same as like for a DSM-5 diagnosis for depression. You're looking at kind of the same criteria there. And so that's going to be at least a 2-week period of functional decline with symptoms such as low mood, anhedonia, which is also known as loss of pleasure, decreased interest, guilt, changes in sleep, changes in appetite, and in more severe cases, you see a lot of you can see some suicidal ideation. And then also, when we're thinking again, particularly about perinatal depression, often some of the low mood and the feelings of guilt are really related to parenthood and then the child themselves.
How do you differentiate between that and postpartum blues, which does everybody get that?
Yeah, so really great question. And, I think it depends a little bit on who you ask. How I think about it is postpartum blues is a little bit of a natural phenomena. We see rates of somewhere between 80 to 90% when you look at the studies. To me, that number says it's a natural process, right? If we're hitting that many individuals having it. And often the way that I'll describe it to a lot of my clients is, many of us who have gone through a menses at least once in our life probably notice like we didn't feel like our best selves kind of the week before. And that's linked to there's just some real hormonal changes that we actually see during that period. That has nothing on the hormonal changes that you see during pregnancy, and I should say more during the postpartum period. So the drop of hormones that you have is huge. And so most people are going to have some type of physiological reaction to that change in hormones. Additionally, if you're bringing a new child home or if there was a child loss, there's a significant change in your dynamic, right? And there's a change in what you're expected to do. And so anyone who's going through that type of transition is going to have, again, some impact on their emotional well-being and their emotional state. And so what we tend to see and how we describe it is about a 1 to 2 week transitory period where some might feel a little bit more emotionally dysregulated. And that'll kind of look like, all right, I found myself crying one moment, but then 2 seconds later, I was so happy to be holding my baby, right? And this kind of like more a larger shift in what they feel like their mood is. But importantly, what you don't see is you don't see a persistent low mood, right? And so if someone's not going to say, oh, I've been feeling sad the entire time and I can't enjoy anything. That's not what you expect to see for postpartum blues. Right. And then same thing, you're not going to see thoughts of not wanting to be alive anymore. When you hear that, we're moving towards postpartum depression.
Got
Okay.
it.
Blues is transitory and you can still feel joy and happiness and these other things. And it should be expected to see something like that when someone's going through transition. Postpartum depression is a much more kind of like severe version, or I don't want to say version, but you see more persistent symptoms of depression.
I really appreciate that explanation. Thank you. Just what might be a very naive question. Is menses the same thing as having a menstrual period?
Yes.
Okay. I heard you say it twice and I was like, I think that's what that means. Thank you so much. I appreciate that. So what are the kind of treatments that are available?
Yeah.
Is it
So it really
medication,
depends.
therapy?
I apologize. I didn't mean to interrupt you
Oh,
there.
no. Good. So what are the kind of treatments that are available?
Yeah, so it depends on the severity of the psychiatric illness as well as patient preference. But in general, if someone is more kind of thinking about like a mild to low moderate depression, we'll recommend a first trial of therapy alone. And there's a few different types of therapy that we tend to think about more for like a postpartum depression. So that might be something like IPT, which is also known as interpersonal psychotherapy. And this is actually a much shorter course of psychotherapy, so usually less than 12 sessions. Okay. And then there's also kind of supportive psychotherapy, traditionally sometimes referred to as talk psychotherapy or psychodynamic psychotherapy. And then there's also something called cognitive behavioral therapy, and that's a little bit more skills based. And all those do have pretty good evidence in terms of postpartum depression. And then for those more kind of moderate to severe forms of depression, we usually recommend dual treatment, so both medication and therapy. And then the current standard of care when it comes to medications are going to be those traditional antidepressants that you hear about, so Zoloft and Lexapro. And then I would be amiss not to mention the new one that came out recently, zuranolone, which is an oral medication that can be given in the immediate postpartum period. It's not one that has been used that much yet, and so there's a lot, I think, questions and things for us to learn, but it really is an interesting one because it could potentially actually have a much faster onset of effect as compared to some others.
Wow. So it's also good to know that it's evolving as the field is evolving, the treatment types are evolving as well.
Yeah, absolutely. And again, I think just like touts that people are finally recognizing how important this is, and to have a new medication like zuranolone that it's really based off some of the data around there being changes in kind of like neuroactive steroids during the perinatal period, and having a medication specifically for that, that's amazing. I don't think would have happened 20 years ago because we weren't studying these things in that manner.
Yeah, that's so great. So let's switch topics, or not topics, but let's switch the conversation a little bit to postpartum anxiety and OCD.
Yeah.
How does that differentiate then to depression?
Yeah, so it's a little tricky. So when we're thinking about kind of like perinatal anxiety, that's a bit of like an umbrella term for various different type of anxiety disorders. So that can have things such as like postpartum OCD, but also postpartum PTSD will sometimes kind of fall underneath that as well, right? But in general, we're thinking about how do you separate it from depression. You're going to be thinking that the anxiety, which is usually things like what if thoughts, ruminations, catastrophizing, is the lead. Okay, but you'll often see it be comorbid with depression and anxiety. Often I'll have patients describe the anxiety came first and it became such a toll on their body that then the depression kind of came afterwards. And so they would get a
Oh.
primary diagnosis more of anxiety with comorbid depression. Okay, which is a little bit different, but it can be hard to kind of tease apart the two. But then specifically talking about OCD, because I think this is one that's really important to understand. And there's a lot of, I think, misinformation out there. This one is marked by intrusive thoughts, okay? And these intrusive thoughts are generally what we describe as ego dystonic. What that means is that they do not fit usually with what the person is necessarily thinking, right? And so, for example, in I don't want to say severe forms of OCD because this is common what you can see sometimes is sometimes people have thoughts of harm happening to the child, and that can be them harming the child. So, for example, like having keep getting images of hurting the child with a knife, but the mom is terrified. They are extremely distressed, and so they will actually put all the knives away. That'll be a little bit of like their compulsion behavior that we'll see in OCD, but they'll keep having the thought over and over again, right? But it's important to recognize that those are intrusive thoughts there, right? That again are ego dystonic, and the risk of there being harm there is very, very minimal, like if existent, to be honest. And so it's important to understand that difference there for OCD. Other kind of common themes that you'll see for OCD is like contamination. So having a fear that maybe the breast milk has been contaminated or the food that they're giving the baby isn't good enough. All right. And then you'll see a lot of illness anxiety as well. And that can present as fear that the child is sick, but also fear sometimes that the parent is sick. And so I'll often have people say, like, they keep having images that themselves or their partner is going to have cancer. And then what happens if the baby isn't there? But they can't get those images to stop. So we can sometimes see that with perinatal OCD.
I have three kids and was pregnant three times. I remember with my third, I just kept having these images, or I can't remember if they were nightmares or images of me falling down the stairs while I was holding him.
Mm-hmm.
So I mean, I think there's probably like so much of this where some of it is common and you
Mm-hmm.
know, as part of just the anxiety of being a new mother and having a new baby, and then other times it becomes more severe and
Yeah.
you know, and requires more of a treatment.
I appreciate you saying that. And yeah, so again, kind of thinking about that postpartum blues, where we said like 90% of people are going to kind of have a little bit of an up and down, right? The same number we think about for people having some type of intrusive thought during pregnancy and the perinatal period, because your brain is literally on hyperdrive of, okay, there's someone I have to take care of now, right? So we expect you to have some level of anxiety, some level of intrusive thoughts, right? So that comment kind of in the beginning, oh, like I'm concerned my baby might stop breathing, so you check once or twice at night, right? That's normal. When we get to, I'm concerned about my baby not breathing at night, so I've now woken the baby up 10 times at night, I haven't slept at all in 5 days, then we've hit kind of thinking more about perinatal anxiety and perinatal OCD. And so it's really about the severity and what is the level of impact on the individual and their child. And so it's about when we kind of cross over. But I really appreciate you bringing up that point because that is so incredibly true. Almost every mom is going to have some level of intrusive anxiety thoughts in the beginning.
So what advice would you give clinicians who have, you know, someone in their office that's, or I guess virtually, or you know, in front of them
Mhm.
that are sharing some of these symptoms?
Yeah. So I'd say, honestly, stay calm first and just kind of be curious and ask questions and really understand where the anxiety is coming from. Is there anything that they're doing to bring down the anxiety? Right. And then how much is the anxiety thought itself matched with reality? Right. So again, OCD, it's not going to be matched with reality often. Right. And so that's really important to know. At the same time, it is important to make sure that you're differentiating kind of like perinatal OCD from psychiatric illnesses that can be associated with some harm. And so, for example, in postpartum psychosis, you can sometimes have thoughts of harming the child that are what we call egosyntonic. And so they actually kind of match what the individual is thinking. And that's because there's a psychotic process going on. And then when that happens, that's what we consider like a psychiatric emergency. Okay. And so it's important to be able to separate them out. How you can separate them out, again, is an egosyntonic or ego-dystonic thought, but also if you're more on that postpartum psychosis side, you're going to see signs of psychosis. So the person's not going to be linear when they're talking. You might hear some disorganized speech, behavior, language, right? So you're going to kind of be making sure that you're picking up on these other things to really kind of make you feel confident that you have a postpartum OCD diagnosis, right? But this one's much more common than the other. Usually kind of thinking it's this works better for you, right? But you want to make sure that you're thinking about safety and catching anything that could be going awry here.
Okay, this is great. So before we move into postpartum psychosis, I didn't even know there was such a thing. What are the treatment options for postpartum anxiety and OCD?
Yeah. So it's similar in terms of how we think about depression, where mild to moderate is more going to be therapy, and then moderate to severe is going to be your usual dual treatment. But there's some differences in terms of like which ones you necessarily pick. So for more kind of like an OCD therapy, kind of the best evidence is for that CBT, so that cognitive behavioral therapy. And in particular, there's something called ERP, which is exposure response prevention therapy. And basically this idea is, okay, you're having this anxiety thought, rather than do something to avoid the anxiety thought, which is just going to reaffirm that you should be anxious about this. We're going to actually have you engage. And so, I keep talking about this idea of like hurting baby with a knife. With ERP would be, okay, you're going to hold a knife, right? And you're going to cut, and we're going to see how you do, and moving in that space until you extinguish that fear. And so that's more of kind of what ERP looks like. And the evidence is very strong for that treatment and that type of therapy. But you can still do things like supportive therapy and IPT, depending on the level of severity that you're experiencing. And then in terms of medication treatment, it's going to be your typical antidepressants again, so your like Zoloft, your Lexapro. But I'll say clinically what we find is you usually need slightly higher doses sometimes to really hit anxiety versus depression. Not always, but I do sometimes when I'm working with my trainees say like, you guys not be scared to push up a little bit more for anxiety, and you'll sometimes see a real difference made there.
So it's interesting. It almost sounds like, but correct me if I'm wrong, that the treatments are similar as the same as you would for OCD, whether
You mean
it's
for depression?
yeah, or just like, because when we think about ERP, we think about normal, like not traditional OCD that's not perinatal. So is the treatments oftentimes similar for the condition?
Absolutely.
Whether
Absolutely.
Yeah.
My apologies. What were you going to say?
I was just going to ask, so is the perinatal OCD treatment very similar to what would be traditional OCD treatment? I don't know if traditional is the right word, but
Yeah, absolutely. So you'd be using some of those same kind of base principles for perinatal OCD. Often the additional piece there is that there's often a child involved, and so how you get that that child involved as well, and making sure that you're repairing any type of like relational difficulties that develop because of the OCD, and really keeping into mind things such as bonding and some of those experiences. And so you're kind of like adding an extra layer, but that core, that base foundation is very much the type of same OCD treatment that you would do outside of perinatal OCD.
Great. Okay, so that is a wonderful extra point to realize. So it's somewhat similar, but then you always have to take into account we have a new mother in this, and there's then that family unit that goes around them, and what are the implications around them. Absolutely. So now let's talk about perinatal bipolar and also postpartum psychosis.
Yeah, so it's tricky. We put them together, but they're somewhat separate things, right? Okay. So bipolar disorder is more kind of like of a chronic illness where people have a mix of manic and depressive episodes, right? And so during the perinatal period, these individuals can have exacerbations of either of those states during this time, right? And then what postpartum psychosis is is we tend to think about it as particularly a period of it's like a mood and psychotic episode brought on by some of the hormonal changes related to the perinatal period, and really the postpartum period is where you're going to have the highest risk there. We often say that if someone has a diagnosis of postpartum psychosis, it's bipolar until proven otherwise, because we do see that a lot of individuals, even if their first episode is the perinatal period, they later go on to develop kind of more of that classical cycling that we see with bipolar disorder. And I will say that is not true for everyone. There definitely is a group of individuals who only ever experience something like a postpartum psychosis or a mood psychotic episode in the perinatal or postpartum time. And so there's something a little bit different there where it really is likely just like primarily linked to the hormonal changes that we see there. Okay. But the treatment in terms of medication tends to be the same if we're thinking about this as like a primary bipolar or a primary postpartum psychosis. Okay. And then I guess just to like flesh up postpartum psychosis a little bit more. So usually when we're thinking about this, it tends to have an onset within the first 72 hours to first month. That's going to be your highest risk period, but we can see it even afterwards. And it's really kind of marked by a time of, potential psychosis, so delusions and hallucinations, as well as kind of like disorganized behavior and thought. Okay. But it can be really, it is a tricky one to sometimes pull out because it can look like someone who's very depressed and maybe isn't talking as much, or it can look a little bit more like mania. And so you really need to do your due diligence when you have a concern that there's some postpartum psychosis there.
Wow, it's a lot. It's a lot to think about, and it's nice that there's kind of a different approach to these different ones and very clear different symptoms so that you can kind of make those determinations. How common is it? And
So
who's
this one is much rarer. So it's about 1 in 1,000 live births. And highest risk is going to be for individuals with a history of bipolar disorder, anyone who stops their psychiatric treatment suddenly during pregnancy, and then anyone with a family history or personal history of postpartum psychosis. Those are going to be your biggest risk groups right there.
So for our clinicians who are in private practice, what advice would you have for them if they saw someone in their practice that they were concerned were having postpartum psychosis?
So I'd say the first thing is safety. So postpartum psychosis is unfortunately linked with higher risk for infanticide, as well as maternal suicide. Okay. And so we really want to make sure that everyone involved is safe. So that will often mean calling the family and confirming where the child is. And then for the individual, really thinking about, okay, how do I get them to the hospital? Right? Because generally, if we're thinking about postpartum psychosis, as I mentioned before, psychiatric emergency. So you want them to be evaluated in the ED in a psychiatric hospital so that you can very quickly do treatment, because it also can come on like this. Right.
Oh, wow.
So like things can change very quickly. And so if you're concerned about that, just kind of have them potentially go to that.
Okay.
I want to be careful how I describe it though. I think sometimes issues you run into is people with OCD get sent to the hospital, even though they don't have any of these other signs of psychosis. And that in of itself can be a really uncomfortable experience of removing someone from their child, right? And so you want to make sure that if you're doing this, you feel confident. And if you don't feel confident, call a reproductive psychiatrist, talk to someone, get a little bit more information. But if you're concerned, hospital is where someone needs to be for postpartum psychosis. That is the recommendation.
That's great advice. So when you say that you have to be careful, how does one separate postpartum OCD from postpartum psychosis? I mean, you touched about it a little bit, but do you have sort of a clear, this is the delineation, or this is kind of how you would separate it?
Yeah. So again, if you're not sure, call someone.
Yeah.
And like how you really delineate it is, what are you seeing with the person in front of you? Are they talking to you clearly? Do they seem distressed by the thoughts that they have? Right? Are they letting family know? Are they coming here and telling you immediately, like, I'm having these thoughts and these are scaring me? This all tells me OCD, right? This is someone who is scared of the thoughts that they're having and wants to be in treatment. Where I start leaning more towards, oh, is this a postpartum psychosis? The person comes in and they can't look at me straight, right? Or it looks like they're carrying things, or they're not organized in their speech to me. They say things like, or they'll describe, I sometimes have thoughts about harming my child. And you ask, what do you think about that? Well, maybe it would be the right thing. Maybe this is what God wants. And we actually call that particular piece something called like an altruistic delusion, is a little bit of a term we use, which is this delusion that it feels like it's the right thing to harm that child. Again, this idea of ego synchronicity, right? And so those are the signs and symptoms that have you leaning more towards postpartum psychosis. Also say like a very classical presentation is they're also not sleeping, because we do think about it as kind of like a mania. And so if you have an individual who you ask, oh, are you able to sleep when the baby's sleeping? And they're like, no, because I'm just wide awake and I don't feel tired at all. That leans me again more to postpartum psychosis. Okay. And so these are kind of like the little things that you start to pull out to really kind of understand what's going on.
I feel like this is something we see played out in movies sometimes and in stories. And, it's like maybe we've all seen versions of it before, but it's very real. And so, I appreciate all of this. What does recovery look like?
Yeah, so that's a really great question. And it obviously looks different for each individual, and it depends on how quickly they were able to get into treatment. Because I'll say too, if you catch postpartum psychosis early, you could be surprised at how quickly you can treat it, right? Before it's necessarily kind of like having more prolonged psychosis and delusions that are there. But for individuals who have maybe a slightly more prolonged course of illness, whether that's pre-treatment or even the treatment itself takes a little bit longer, we can see that have a real impact on how they view themselves, but also potentially the relational impact between them and their child, right? And so often we're thinking about the recovery process. Some of it is medications, right, which is so important for postpartum bipolar disorder, your mood stabilizers, your lithium, things like that. But it's really important to also think about it from more of a therapeutic and psychodynamic approach. And one of the things that I will often recommend for some individuals is actually something called dyadic therapy, which is therapy that's specifically kind of around thinking about that relationship between mom and baby, right? And kind of helping people work through some of the challenges that might have arisen when there was some postpartum psychosis during that early period of child development.
So when we think about, and I get we're calling it, postpartum, but OCD, anxiety, psychosis, depression, does any of this ever show up while someone's pregnant?
Yes, absolutely. So I think I mentioned a little earlier, more using the term perinatal depression,
Yeah.
because we really can see it start a bit earlier. And you see that too with some of the, even like things such as like postpartum psychosis, where you can see a little bit of some of these symptoms starting earlier on. So I can say in my practice, usually, what I hope is the more typical, doesn't always happen this way, but people reaching out to their mental health providers actually pre-conception. Right? One, if they're on medications, to talk about them and understand kind of the risk of being on and being off. But two, so that they can actually start to build a relationship with the provider who knows them well and can follow them during pregnancy. And so I tend to meet my clients once a month or so during pregnancy, so that I can really kind of catch if anything's going maybe not in the direction that we want it to, and make adjustments early.
All right, I'm so fascinated with this field because I think so many therapists would say it's so hard to get access to a psychiatrist, right? And you're a specialist. Like how do you get your clients? Like is it, or your patients? Is it something that happens, like you said, early because they're high risk in the pregnancy? Is it, do they come after? Like is there a typical way they come to you?
Yeah, so I see there's a few different ways, and it's a little bit based on kind of like how our program is set up. And so we have some providers from our WARM program who work in the on the OB unit in the hospital. And so they're kind of what we call CL psychiatrists. And so if someone's coming in and they're pregnant and they're showing symptoms of depression or something like that, they'll often be linked automatically to our clinic. And so we'll kind of see them then. And if they have another child, they're linked to us already, right? And so that's one way in which forge relationships develop. Additionally, we are online. And so often people will kind of just know, they'll be like looking up, I have questions about my medications, and will come up. And then I think in general, we also do a lot of work with trainees. And so we do a lot of the teaching around like reproductive psychiatry. And so any trainees who are working with individuals will often say like, oh, can you come and do a consult for one of our clients? And then when they graduate, they're often doing the same thing. And so we'll find that other psychiatrists and other therapists will refer to our program when these questions kind of arise.
That makes a lot of sense. What about reproductive endocrinologists?
Yeah, so we work pretty closely with them. And so, we have like various different people who actually come and do kind of like talks for us. We do like a didactic series. And so sometimes reproductive endocrinologists that we have relationships with will come. And so they'll often kind of like bring us questions even during their didactic sessions. And then likewise, we try to kind of go to them as well. And so we build a relationship that way.
It feels like this should just be a requirement of, like you had said earlier, that the, OBGYN is doing the screening, and that we're hitting this on the prevention side. Because it does feel like the more people are educated about it, it's common enough that it will help them kind of know what the skills are. And then maybe also the partner, and having them being aware of the potential so that they could, be good support systems during these times. Are you feeling more optimistic about?
Yeah. Just like about people knowing about it? Absolutely.
Yeah.
And again, you mentioned earlier, I'm the fellowship director, right? So I am someone who believes so strongly about education in this field. Half of the population are people who potentially have a child, right? And so it's so important for anyone who is a psychiatrist or mental health provider to understand at least the basics of what this is, right? And so for me, one of the things I really try to do is I do trainings for the residency class, because I'm going to do my best to make sure they leave and they at least feel comfortable if a pregnant person walks in of like, what do I do? Right. And then I do the fellowship training, which the goal here is more kind of specialized training, because you can imagine there are a lot of complex questions that come up around medication management and other things. I don't expect everyone to be an expertise in that, but I do want to put more experts out into the world. And in particular, I also really want to put more experts out into the world who are able to do that with underserved populations, and trying to be really mindful of that. Because you were mentioning, I'm a specialist, so it's already kind of hard to get to me. It's extra hard to get to a specialist within certain communities, right?
Mm-hmm.
So trying to increase that access is a big part of kind of the work that I do.
Well, it makes me extra appreciate your being on this podcast, because it's a really good way to, try to reach other clinicians that are, seeing someone, and just the normal conversations around it feel like they could be very, very helpful. Let's talk a little bit about substance use in this kind of perinatal period.
Yeah.
As I mentioned, I was pregnant 3 times, and my kids are 21, 27, and 30. And there was the rules kept changing as they continue to change, right? So I think, just talking about the normal stuff, right? Like you couldn't have any drinks, and then it was like you could have some wine, or, so I mean, it's a little bit of kind of a moving target again, like, people can feel depressed, and they can also, and feel postpartum, but that actually depression, or, that it needs treatment.
Mm-hmm.
Talk to us a little bit about substance use.
Yeah. So goodness, I guess I'll start with just some stats first. So if you look at kind of SAMHSA, they say about 8 to 11% of women during pregnancy use some type of substance, whether that's an illicit substance, tobacco, or alcohol, in the last like month, when they kind of like do like more of a prevalence study. So that's a decent amount of individuals, right?
Yeah.
And we're finding that for not all the different groups, but some of the groups for particular substances are increasing. And so, for example, marijuana current averages are like 4 to 6, but really I think those numbers are probably higher, and we haven't necessarily caught them, but we expect those to continue to increase during pregnancy, right? And it is so important to be really mindful of substance use in pregnancy, because it can have significant implications on someone's mental health. And so I think a little bit actually again about that New York State data. We were talking about 1/3, or not 1/3, sorry, mental illness being like the third leading cause for maternal mortality. When you actually look at factors that are associated with some of these deaths related to mental illness, substance use was around like 86% of a factor in these, right? And so it's such an important thing to kind of think about how it actually impacts the mental health of these individuals who are pregnant and postpartum. Okay? Often when I'm kind of thinking about also the period of pregnancy and postpartum and substance use, they're a little bit different, right? So often in pregnancy, though we still see relatively high use rates, overall, most people you're going to see potentially like kind of like a decrease in the use or a little bit more of an interest in actually doing treatment. And so pregnancy can be a particularly kind of like unique time to actually get in and really start doing treatment and providing psychoeducation with individuals, all right? You run into a little, but it's not protective. I want to make that clear. It's not protective, but it's a unique opportunity often. The postpartum period is, and again, I want to be careful with my language here, but a little bit more uniquely potentially deleterious when it comes to substance use. And that's for various different reasons. Some of it is that people just don't have access to care a whole year postpartum now, right? And so they're actually just not involved with their providers as much. And if you just had a child, you're more stressed, right? Like I think we can all kind of think about there's just a kind of a change. And so we actually do see when most of those kind of like maternal mental deaths that are related to substance use occur, they actually occur during the late postpartum period. And so it's really important for providers to really think about how the stress of the postpartum period might potentially lead to an increase in substance use and continue to screen and assess throughout.
Is it, because now you got me thinking about a whole bunch of different things. When we think about, so I've never even thought about marijuana use, and it's true. I mean, that has changed so much now in more recent years. Is it different between you're taking medications or what you take? That I would imagine your OBGYN works with you and says these are good medications to take or not take. Are people, when that was at 8 to 11%, are they doing it off label, if you will? Like they're doing it because they I don't know the correct way to say this, but like they are stressed. This I'm talking about now in pregnancy. Or are there times that, they think that it's like the right thing because they're feeling stressed, and so they're using marijuana to, relieve stress maybe, and then they think that could help. I guess what my question and on this is that, are there times where this is I can't, I'm like I'm trying to come up with how I'm going to make
asking like, is sometimes using the substance like reasonable if it's like helpful? And I think that's like a very, very complex question, and one, it definitely depends when you're thinking about like what is the particular substance, right? So we have more evidence about some of the potential negative effects of alcohol at any stage point, because there are some studies that suggest, obviously for early and like first trimester, but even late trimester, we can see some potential changes with more consistent alcohol use, right? And so there's a little bit more evidence to say like, okay, really get started thinking about kind of something else for treatment, whether that's medication or therapy, because often the medications that we have do to have a higher safety profile. And then additionally, when we're thinking about things like alcohol, we know that alcohol itself can be linked with mood disorders. And so we see things like alcohol-induced depression, right? And alcohol-induced like other ones. And so we don't want people on an agent that could potentially make things worse, right? And so the evidence is a bit clearer for alcohol, like, okay, probably not. For more recreational use, again, still probably not. And like, is it going to cause significant harm? I think that some of the information there is less clear. For marijuana, it gets even dicier because we just don't have the studies, right? Yeah. Because since it's considered an illicit drug from the national level, it's hard to really do like well or not well thought out, but well-developed studies because of like the legal complications around it, right? Most of the data that we are starting to have is that it's probably not awful, okay? But I don't have any data that it's good. And so it's definitely not something that I would recommend for use. And then most of the studies that we have are based on marijuana usage years ago, which is not the same marijuana that we're seeing now. And I don't think you
Yeah.
can extrapolate that information, right? And so as a baseline, we've helped for individuals to avoid marijuana during pregnancy because we just don't know what those full outcomes are on the child. And then again, kind of like with alcohol, we do find that for certain people, marijuana does increase their risk for certain illnesses, including things like depression, but also some of the ones that are related to reality. So some psychosis there and paranoia. And so we can see that, right? And so, for example, if someone has postpartum psychosis, I'm going to be like, oh my goodness, no, like, how do we get you off marijuana? Like, get you something else. Like,
Yeah.
you're going to be really kind of mindful of what's the person in front of you. Right. But it's a complex conversation. And I personally take it more from like a risk management one. And so
Mm-hmm.
work with individuals. So like, how can we reduce the risk as much as possible? Right. The reality is your provider tells you to just stop, but you're not understanding where it's coming from. The use, that's not going to go anywhere and you're not going to have a good
Mm-hmm.
therapeutic relationship. Right. And so you want to really kind of talk and understand.
I think that makes a lot of sense. What treatment recommendations are there for people that are using substance use and
Yeah.
during
So
this time?
I won't get into it too much, but it really depends on the type of substance that you're using. So each one has slightly different medications that you can use. So, for example, for marijuana, sometimes we'll use the things like gabapentin, but you can also use a little bit for alcohol. For opioids, you're going to be thinking about things like methadone, right? And so it's important if someone is having a moderate to severe substance use disorder, really thinking about is medication management during pregnancy going to have fewer risks than continued substance use during that time, right? And so making sure people are connected to the right individuals. And then a lot of it is going to be therapy and really kind of using motivational interviewing techniques as one of the primaries, kind of understanding what's going on and what are their goals and helping people move from that like pre-contemplative or where they are in that pathway to a stage of like actual change. And then whatever you do, medication, therapy, both, being really mindful to again continue it into that far out postpartum period. It's not enough just to do it during pregnancy. It's so
Hmm.
important to do it after pregnancy as well.
Yeah, because now you have this new child
Mm-hmm.
and maybe others. Do you have any stories or client stories or stories that you could share with us that might highlight some treatments that you used at critical times or that have some hope of good recovery or positive outcomes?
Mm-hmm. Yeah. So I think, I won't mention any particular patients, but I think kind of putting some together, postpartum psychosis can sound really scary. And I've definitely had the experience of, individuals coming and saying, like, I really want another child. And I'm really scared about what happens if I was to become pregnant again. And being able to kind of sit with them, talk about the risk. We can never bring it down completely, right? But we can win half that risk for them with the appropriate kind of medication management. And then
Mm.
often, because they're just seeing us, right, and we have such close contact, if it does happen again, we're able to get in very quickly. And so I've had several individuals who have had that prior experience of postpartum psychosis and did not have it on that second time around, right? And so just to know that like that's possible is so important
Yeah.
for so many people who've had a really kind of disquieting first time.
And what are those odds? Like, I mean, if they come to see you and they get help, it sounds like you can help mitigate that quite a bit. But what if they don't get help? Are the odds if they had an experience with one pregnancy that it would happen again?
Yeah, so it again depends on the illness. So postpartum psychosis is a particular one. You can see pretty high risk of reoccurrence in the postpartum period without any type of treatment. For depression, it changes a little bit more of like how many episodes have you had. And so let's say someone's had like a postpartum depression once, but also multiple episodes of postpartum depression. Their risk of having postpartum depression is pretty high as compared to someone who only had one episode of postpartum depression
Got it.
and maybe they had an episode of postpartum depression when like they lost a family member at the same time, right? And so there's other things that are going on that would change kind of the risk profile of having that reoccurrence. Right?
That that makes so much sense. So to summarize, this was so helpful. I learned so much. It sounds like overall, like most PMADs are treated with tailored medications and psychotherapy.
Mhm.
Are there any other ways to support pregnancy and postpartum individuals?
Yeah, so many. And often when I kind of like am meeting with individuals, again, I'm a psychiatrist, so I'm thinking about medication, but it's almost kind of the last thing I think about, actually. It's really kind of like, how do we booster your supports, right? Because
Mm-hmm.
it does take like I don't want to say cliche, but it takes a bit of a village,
Yeah.
right? And so really thinking about how can we support people on this change in their life. And so one thing I often will tend to talk about is actually doulas. And doulas are pretty much kind of their additional support individuals for the perinatal and postpartum period. And it can look a little bit different. Sometimes you're giving more like support during labor, but there are some doulas who are really there for you in the postpartum period and helping around like breastfeeding and eating, kind of like providing some level of child care. And there's good evidence out there that they increase the odds of a positive kind of obstetrical outcome from a birth, right? And it's been lovely, again, we talked about how we're starting to see some changes in the field. Doulas before, they can be expensive, and so not everyone has access to them. But many states now and programs are actually promoting them. And so where I am, my home state, New York, they have both through city and state funding. They've been giving more access to doulas to individuals with various socioeconomic backgrounds. And so that's one area I'm like, oop, okay, this person might need this. How do we get them connected to that? Other things I tend to think about, lactation consultants, right? So breastfeeding can be really, really hard, right? And so letting women know like it's okay to ask for help. And I tell them there's someone in the hospital who can help you, but often sometimes your insurance will pay for you to talk to someone afterwards, right? And then there's also just some wonderful organizations. There's La Lichi, and so people can find kind of support there. And so just knowing that there are people that they can talk to can be really helpful. And then for some individuals, there's things such as night nurses. And so, for example, let's say I had someone with postpartum psychosis, they can potentially actually have like a night nurse come at night so that they can get a full night's sleep. And that can range from, sometimes you pay private, but there are some organizations that will actually provide it for free. And that can be a much kind of higher level of care as needed. Yeah. And then I think probably the last thing I mentioned, which I think I recommend the most to people, is support groups. And usually, what I say is try to find a support group where it's being led by someone who's a mental health provider so that they can really make sure their group is tailored appropriately. But there's so many wonderful support groups. I usually recommend people to go to Postpartum Support International, where they'll have a postpartum psychosis group. They have a postpartum depression group.
Oh,
They
wow.
have people, postpartum after a perinatal loss. And so they have so many wonderful groups, and they're all free and they're all online. And so that's a really kind of like great resource to connect people to.
That is so great. When do you think it would be important or helpful for people to reach out to reproductive specialists?
Yeah, so there's kind of two ways that I think about this. One can just be for like a brief consultation versus actually having your patient come see us. So I'm part of, as I mentioned before, Project Teach, which is just like a phone service. And so literally, if you're just like, I don't know if I can give someone Zoloft in pregnancy, you can give us a call and we'll like answer in 15 minutes, right? So like
That's
any little
amazing.
question like that. And we're not the only one. There's various different ones in other states. They're trying to develop a national hotline right now. And so that's like one kind of like quick way for you to reach
Wow.
out to people if you have questions. If things are a little bit more complicated, often I'll say if there's like mood stabilizers involved or you're concerned about postpartum psychosis, or if the patient just wants to sit down and have like a full conversation with a reproductive psychiatrist, then I would recommend actually like sending the individual for a full consultation with a reproductive psychiatrist, and then they'll do a full evaluation. And then they'll talk to you, right? So I say half my day is actually talking to other providers, like, here's what I saw, here are my recommendations, I'm here if you need anything.
Wow. That's great to know. Okay, that's a wonderful thing. So this was so helpful, so informative. What is the number one thing that providers should take away from this discussion?
Yeah. I think it's that PMADs can have significant morbidity, but importantly, they're both preventable and treatable, right? So there's so much that we could do here.
That's great. So where can our listeners find you? You mentioned the Teach, but where can they
Yeah.
find you?
So I'm part of the Columbia Warm system, and so really just kind of going online and typing in Columbia Women's Reproductive Mental Health, you'll find us kind of there. And then I'm also on Postpartum Support International, and then LinkedIn as well.
And what does the project teach?
Yeah, so Project Teach is a consultation line that we do through the New York State.
Okay, so that's different than the Columbia Warm program.
Yes, so the Columbia Warm program is where I spend the majority of my time. So that's where I'm reproductive psychiatrist and then the fellowship director there. And then Project Teach, I spend about maybe like 20% of my time taking on consultation calls. And that's free for any provider in New York City to just reach out. They'll get immediately connected with a social worker who will kind of like take down some of the information. And then within a half an hour from that period, myself or a different reproductive psychiatrist will call them back. And it's open 9 to 5, Monday through Friday.
Wow, that is really amazing. I had no idea. So thank you so much. I really appreciate most importantly taking the time to be here with us, but equally importantly, actually, I take it back. More importantly, the work that you're doing,
Oh,
because I know it's helping so many, and it sounds like you're also invested in learning along the way and researching these conditions so that we do know more and learn more and all of that. So thank you.
absolutely. And I'll say, too, I'll mention, we do a lot of didactic programming around women's mental health. And so if there are individuals who are curious to kind of learn more about that, we're very opening and kind of let a lot of people kind of join. We are big believers in collaborative work. And so actually every Wednesday we run a pretty large seminar system, which we call warm rounds. And we have psychologists and social workers and psychiatrists and trainees, and we all come together and we'll have like a special guest speaker come and talk about a topic within women's mental health. And the goal is really to kind of do like a little bit more of a deep dive into a relevant topic. So for example, some of the ones we've had recently is talking about kind of like PTSD related to birth. And so those have gone through more of like a traumatic birth experience. And then we've also had individuals come in and talk a little bit more about kind of like what actually happens in postpartum psychosis when there is actually a case of infanticide, and talk even about some of like the legalities and some of the differences that come up there. And so it's really an opportunity for us to really get into kind of a deep dive. And we do that for about an hour and 15 minutes. And we try to get it done every single week. Because again, we really believe education is so important and there's so much to learn in this space. So other people are more than welcome to reach out to me if they have questions.
That's great. Thanks so much for listening to Therapy Cafe, the future of mental health. For more information and resources regarding today's topic, please take a look at the episode show notes. If you'd like to obtain continuing education as a psychologist, counselor, social worker, or therapist, you can purchase a 1-year subscription to Psych Hub's learning platform. Once you're signed up, you'll have access to earn CEs for this and every Therapy Cafe episode. Plus, you'll have access to our existing library of over 100 evidence-based practice continuing education courses created by expert clinicians. Go to psychhub.com/sign up for more information.